So Dr. Quintana was born and raised in New Mexico. She earned her medical degree from the University of New Mexico and did her residency in internal medicine, as well as her fellowship in hematology oncology at UNM. Dr. Quintana has a special interest in hematologic malignancies. Wow, that's a mouthful. And is the adult physician for the Ted R. Montoya Hemophilia Program. So take it away, Dr. Quintana.
Thank you so much, Janet. Thank you all so much for being here. So I am one of the medical oncologists here at the UNM Comprehensive Cancer Center. And I am indeed on call and rounding on our inpatient hematology service this morning. So just a little disclaimer for any strange interruptions. I had to find the most secluded, least likely to be interrupted spot on our oncology floor, and the charge nurse directed me to, there's actually a very nice computer set up in front of me, but behind me I have equipment. So I apologize for that. And hopefully not too many interruptions, but please forgive me if anything comes up while I'm talking. So I'm going to go ahead and share my screen. I have a PowerPoint presentation to work off of this morning. So I want to start by kind of telling you kind of the principles of this talk. Oncology is a really incredible entity within all of medicine right now. And each year I almost find the idea that I'm going to talk about new developments in cancer treatment more and more daunting. We have more medications, drugs, treatments in oncology than in absolutely any other field of medicine, including cardiology and infectious disease, to name a couple that are, usually front runners. Our treatments and drugs are coming out hard and fast. We get an email or 2 or 10 a day talking about this drug is newly FDA approved, and now this was FDA approved, and it can be quite overwhelming. And so, we keep up with our drugs, but to be able to present all possible treatments within an hour to patients who have a host of different experiences is, of course, impossible. So what I try to do in this talk is kind of lay a foundation of a few concepts of ways of treating cancer that may start with older concepts but have newer uses or brand new technologies. And what I want you to take away from this talk is kind of an empowerment to keep conversations with your treating oncologist open, because that is by far and away the most important thing, to have a good working back and forth relationship with your oncologist, so that if something sounds intriguing or you don't understand it, or you think, hey, this sounds like me, you can kind of open that channel of communication. Because to go through every disease and every drug is, of course, impossible in an hour. So let's see. To start by talking about, what are we talking about when we talk about new developments? And this is kind of one of the concepts that I'm referring to, and it's like, what's new? People talk about immunotherapy or targeted therapy or personalized medicine, and you see commercials on television. That's another kind of entity that's come about in the last, it seems like 5 years or so, that there's actually commercials in the middle of your relaxation talking about ways to treat your cancer, and ask your doctor about this drug or the other drug. And so I can see how that can be very overwhelming, or raise a lot of questions about, well, why can't I have that medication? That person looks like they're living their best life. And so there's a lot of hype out there, both on television, just in the news, things you read in the paper, when you hear stories about celebrities, that kind of raise a lot of question. So I always like to talk about, to begin with, When you talk about treatments, I think it's really, really, really important to talk about what the goal of treatment is for your particular cancer. So I think this is, again, one of those things that's incredibly important to talk about with your oncologist. I really try and mean to talk about this with every one of my patients. What am I trying to do with my treatment? One possibility is, are we trying to cure this cancer? Of course, that's always our hope and our goal. That's what we want for everyone. We want to be able to cure every cancer every time. So it's important to know from the get-go, is your intention of treating me to cure me or to do something else? And if the goal isn't cure, then what is it? So another possibility is, might we just be wanting to prolong someone's life? And the name of the study isn't really what's important. It's just this concept of sometimes we can't make the cancer go away and expect to die at a ripe old age from something else, but we can hope to gain some period of time. And sometimes that's a wonderful thing, because that may be 10 years, 15 years, it may be 5 years, it may be much less. So understanding what that goal is, or what the aim or expectation is also something important. Another goal of our therapy, and I think we try as much as possible to bear this in mind with every treatment that we give, is to improve the quality of life. So sometimes we're looking for cure, sometimes we're looking for life extension, sometimes we're just looking for life betterment. Is there a treatment that will improve symptoms? And then ultimately, if treatment's been going on for some period of time and we unfortunately reach the end of what we can offer, we always want to talk about treating symptoms. If we can't treat the cancer, can we treat the pain? Can we treat the nausea? Can we treat the suffering? And so that's something that I hope should be part and parcel of all cancer treatment, is treating not only the cancer, but the symptoms of the cancer. And one concept I also like to bring up in terms of kind of goal number 3 and goal number 4, meaning improving quality of life and treating symptoms. One concept is that when we are trying to cure cancer, when we're looking at goal number 1, we may put up with a lot more toxicity from our treatment. We may say, okay, we just need to do everything we can to help with your symptoms, with your nausea, with your fatigue. But we know at the end of this 6 months, we are expecting to be rid of the cancer forever and put it behind you. And it may be more acceptable to have a high toxicity profile, we say, than if what we're trying to do is gain 6 months, gain a year, gain 3 months. We really want to focus on that time being the best quality it can be. And so it may not be acceptable to put up with severe side effects. Of course, we want to mitigate those side effects as much as possible at all times, but that's also, I think, an important concept. Another concept I like to bring up at the onset of this talk is that, advances come in 2 flavors. And so one advance I've already mentioned, that just the sheer quantity of drugs being poured out of industries, of drug developers. There are lists and lists, like I said, hundreds and hundreds of drugs out there. But those drugs don't do a lot of good if you have drug A that sounds very interesting, very exciting, and we're just going to give it to everybody with cancer. And even that, there's a million different kinds of cancers. And even if you whittle it down to, okay, colon cancer, lung cancer, breast cancer, within even just those 3, there are many, sometimes less than 10, sometimes dozens of different kinds of cancers under the umbrella of lung cancer, colon cancer, breast cancer. They all have their own variations. And so it becomes, the more drugs we get, the more we understand the disease process, the more we understand what drives a cancer, and then the treatments come, the more important it is to know we can't just give this treatment to everybody with colon cancer. It doesn't work in everybody. But if we can figure out which patients this treatment works for, that is very, very important. So for using that example, if we take a new, let's just say, let's use lung cancer as an example. We have a new drug and we give it to everybody with all lung cancers across the board. We may only expect to see 5% of patients benefit from that drug. But if we can figure out, if we can come up with a test, an assay, something specific about that cancer that we can identify and say, those are the patients that are likely to respond to that drug, then for those patients, the percentage of those patients that may benefit may be as high as 100%. And what's important there is then the response improves for the whole group. For the group that is likely to respond, we improve their chances of response and survival. For the group that's not likely to respond, we improve their chance of survival because we don't waste their time with a drug that was never likely to work for them. And so, well, the physician scientists and the lab researchers are developing these new drugs and then taking them to industries and producing these drugs. That's a very important part of new developments in care. Our pathology colleagues are working to help us identify things that we can do when we have your biopsy, when we have your surgical specimen, and we're working on it to see what drugs may work. And that's also very, very important. So, I'm sure there are many of you with many different experiences in this virtual room. And it may seem like once you have your biopsy done or once you have your surgery done and you're waiting to see what's going to be done with it, it seems like forever that the pathologists are working on it. But these are the kinds of things that are being done. And so that's also a very important advance that is also coming hard and fast. So again, that just the second part of that graph that improves the survival for the whole group. So now let's talk about a few treatment strategies. And again, I'm kind of grouping strategies into groups and ideas more than talking about any one specific drug. And I like to talk about the old strategies and the new strategies, just to kind of put things in a framework. And by old strategies, I always put this picture of a classic car and then a fancy new car. And the reason I do that is to say, just because a strategy is old doesn't mean it's invalued. If there's someone outside the store, hopefully not. Just because a strategy is old doesn't mean that there's no value in it. And usually what I mean by saying old is kind of good old fashioned chemotherapy. Our oldest chemotherapies, the kind of traditional chemotherapies where you have a very kind of the thought that comes up. Give me 1 second. So sorry, I'm going to interrupt, or I'm going to put my mask on for just a moment because someone's in the room. You have a kind of traditional thought of someone sitting in a chair. You have hair loss, you have nausea, you have fatigue, you don't feel well. And that, when we talk about new treatments, sometimes people will say, why are there all these new fancy things and you're still wanting to give me chemotherapy? Chemotherapy still has a very important role in the treatment of cancers. And there are some cancers that just respond well to chemotherapy. There are some cancers where that really is still the best standard of care. And so this is where that trust and relationship with your oncologist lies. If your oncologist is saying, we're going to just use plain old chemo, it's okay to ask questions, but know that it's not because your oncologist is necessarily old fashioned or not using the newest, latest, greatest things. But there is many of the newer drugs are kind of a bit more refined. And so the question is there a better way than old chemotherapies you can kind of liken to a giant bomb going off? Old chemotherapies, most generally, in many of them, get into cells at the level of DNA. And so they look for cells that are dividing quickly. Many of those are cancer cells, and they go in and damage the DNA so that all cells that are dividing quickly die. And so you kind of have death of the bad cells, which is great, but also that leads to a lot of side effects, death of good cells. And so the question is always, well, if you just have the one cancer and you can identify like a cockroach, if you can just identify the cockroaches and just kill the cockroaches, but leave everything else, wouldn't that be nice? And so that's the idea behind many of our newer therapies. What this slide is showing you, before we get into some of the nitty-gritty concepts of some of the newer drugs, this is a schematic picture of a cell. So imagine that this is a cell in some organ. And what this is the surface of the cell. This is the outside. This is the inside of the cell. And down here in the middle, this is the DNA. And when the DNA replicates, that'll tell the cell, make a copy of yourself. And usually, in a very simplistic, gross sense, what a cancer is a cell's mechanisms to divide and make a copy of itself, but know when to stop, is broken. And it keeps dividing and making replicas of the cell that becomes less and less and less functional without any concept of, okay, now I have to stop. Now I'm too big. Now I'm invading other organs. Things are out of control. And so for that reason, old chemotherapies get in at the DNA level and say, okay, stop the division and kill this cell that's not doing anybody any good. But between the surface of the cell and the DNA, there's a million different cell signaling pathways, we call them. And they may react to something on the outside of the cell that stimulates all of these different pathways to talk to each other and ultimately tell the cell, make a copy of yourself. And we're learning more and more that different proteins, different pieces in these pathways in different cancers are broken and they don't function correctly and they don't tell the cell to stop dividing. And so many of these various pathways are the targets, are the kind of vision of, okay, let's get in there and stop this pathway so this cell stops replicating out of control. But you see how complex, this is just a very random schematic of one cell, but it's just to show you how complex these cell signaling models are. And so if you stop one pathway, the cancer may get around it by going down another pathway. But this is where we've learned more and more and have more drugs to target more proteins to help and to modify the behavior of cancers. So I wanted to start by talking about the concept of immunotherapy, because I think that's kind of a catchphrase out there. You hear about immunotherapy, and I have patients come in all the time asking me, why am I not getting immunotherapy? What is immunotherapy? So it's definitely something out there. And in general, to me, an immunotherapy is something that uses the immune system to prevent or treat a neoplasm or a cancer. And oftentimes immunotherapies will enhance the body's own immune system to respond against tumors. And I think this one concept in oncology that's kind of been evolving over the past many years is the idea that, in a sense, cancer is a bit of a failure of our immune system to clear it. Could we harness that? There's an immune system is an important piece of recognizing a cancer and getting rid of it. And so we're kind of learning more and more how to harness that immense power that our body has innately to help treat cancers. So one concept, like to me, a basic immune therapy, I think we can use that word, is a monoclonal antibody. And I use this drug, rituximab, which is by no means a new drug. Many of you may know it from your own treatment or treatments of others, but I just use it as an example. Rituximab is a monoclonal antibody that is manufactured, and it targets a surface marker on B cells. B cells are a part of our immune system. B cells are some of our cells that form antibodies. But many B cells have a marker on their surface that's characterized by these little red lollipop looking things. It's called CD20. Rituximab goes to CD20 and then kind of starts a chain reaction to have the body's immune system then go in and kill that cell that has CD20 on its surface. So specifically, rituximab is used very frequently in the treatment of many non-Hodgkin's lymphomas, which are started which are a cancer of B cells and have that surface marker. And it's incredibly effective. It's enhanced our ability to treat B cell lymphomas immensely. So I just use that as an example. And this is just another schematic where here's CD20, rituximab comes in and attaches only to CD20, which is only going to be on the surface of B cells, so more specific than something that goes in and kills random cells. It kills only B cells. It doesn't kill B cells. It attaches to B cells and then causes an immune kind of avalanche within the body to kill those cells. This is just a very small list of other monoclonal antibodies that are used in cancer. This is a tiny list compared to what exists. There's alemtuzumab, also used in lymphomas, bevacizumab or Avastin, used in many different kinds of cancers, brain, colon, kidney, lung, cetuximab, used in some head and neck cancers, ibritumumab, used in other lymphomas, ofatumumab, panitumumab, used in some colon cancers, trastuzumab, used in breast cancer. So many different, anything that ends in MAB is a monoclonal antibody. And there are many, many more, but that's an idea of how you can use the body's immune system to target and kill cancer cells specifically. Now, here's something that's a bit more of a cutting edge technology. CAR T therapy stands for chimeric antigen receptor T cell immunotherapy. What this is, and again, I show this, there's a few different cancers that this is used in, but it is a very exciting therapy. So CAR T therapy, what we do is we take the patient and take off T cells. T cells are a part of cells of the immune system. And those T cells are then modified in a lab and then expanded. The lab modifies them to make them recognize something about the patient's specific cancer. So it takes an immune cell out of the patient, modifies it so it's anti-cancer, and not just any cancer, something specific about that patient's cancer. Then that cell is expanded in the laboratory, and then together with a small dose of chemotherapy given back to the patient. And so now you have kind of modified, manufactured immune cells put into you that are then surveying your body to look for that cancer. And when it sees that cancer, then it says, that's bad, we've got to kill it. And it's looking for something specific on that cancer. So again, it's not this like bomb of chemotherapy killing everything, it's killing very specific things. So this is a technology that is in many cancers still being investigated as a part of clinical trials. It is currently FDA approved for some childhood leukemias, for adult non-Hodgkin lymphomas, and is being kind of expanded to more and more things. It's there's an FDA indication for multiple myeloma, which is a hematologic malignancy, usually in adults. But this is very exciting therapy. So just an anecdote, I had a young man in his 20s years ago now, probably, it must be probably 8 years ago, who had ALL, which is a leukemia, usually more frequent in children, but can happen in adults. And we were pretty much out of options for him. We were even starting to talk about moving towards comfort measures and really not much else to offer. But there was a clinical trial utilizing this technology being done in New York. And I was able to talk to the trialist there and secure a spot for this patient. He went on to have this therapy. And then because we weren't sure if it was needed, he ended up having a stem cell transplant as well. And this patient now just kind of sends me pictures of his family, pictures of his new baby girl, pictures of the amazing things that he is doing here in Albuquerque. And it's really remarkable. So this is a very powerful therapy that's a new kind of technology. Another idea, again, concept, so something different, is something called BiTE therapy or bispecific T cell engager. It's a similar concept though. The idea is that it's a drug that links your immune system T cells. So rather than taking the T cells out and manufacturing them, the drug is given and it links your immune cells, your T cells, to your cancer cells. So there's something in the drug that recognizes a T cell, and then something else that recognizes something specific on the cancer cell. So it kind of marries, it forces the immune system into the same kind of fighting ring, the same battle cage as the cancer cells, and so causes immune-mediated destruction of those cells. An example of this, there's an IV drug used for relapsed acute leukemia, blinatumomab, but there's others in development for many different types of cancer. So BiTE therapy is another kind of exciting cutting edge technology. I think this, I want to skip ahead to this because I think those slides kind of belong after this. Sorry about that. Another concept in immunotherapy, and this is, I think, what most people are really talking about when people use the buzzword immunotherapy. Oftentimes we're talking about this concept, programmed cell death protein 1, or you might hear your oncologist talk about PD-1 or PDL-1. This is a relatively new class of drugs that are inhibitors that activate the immune system to attack tumors. There's a lot, I find that when you describe these drugs in medical terms, there's a lot of double and even triple negatives. It can be very confusing. So I heard Dr. Adler, one of my colleagues who works down in Las Cruces, describe these drugs once, and I think he does it best. So I hope he hasn't copyrighted his description. I don't know how many of you are Harry Potter fans. I have young children, so we're definitely Harry Potter fans. In Harry Potter is a wizard and he has a cloak of invisibility. And when he puts this cloak on, he's invisible. Cancer has a way of evading our immune system, of getting away from our immune system because it makes itself invisible to immune systems. Frequently, it's again that concept that cancer is almost a failure of our immune system to recognize it. There's something foreign in our body. Why can't our body recognize that and get rid of it? And it's because cancer tends to surround itself with these proteins that cloak it, that cause it to be invisible to our immune system. These inhibitors, these immunotherapies, go in and link themselves to the cloak of invisibility. They link themselves to those proteins that cause our immune system not to recognize the cancer, and they tear it off. And so they expose the cancer to our immune system and cause our immune system to go in and destroy those cancers. The two oldest drugs in this category, one called pembrolizumab, that was FDA approved in September of 2014, initially for metastatic melanoma. It now has a million more indications. Nivolumab was introduced or approved in December, just a few months later, also for metastatic melanoma. Both quickly went on to gain more and more FDA indications. I think the next one was for squamous cell lung cancer. Now they're used in several lung cancers. They're used in sometimes colon cancer. They're being investigated in breast cancer, in Hodgkin's lymphoma, and several others. These are drugs that are being investigated in almost every cancer that exists. And these are only two drugs. Now there are more and more and more immunotherapies coming out with this same mechanism. And many of them are kind of labeled to, with this one we use more in such and such cancer, and this one we use here. But they all have this same concept, this same idea that they are going to use your immune system to fight cancer. Now, I always especially hear, because these are exciting drugs, but they are also, and this is the same with everything that I've mentioned so far and everything that I will go on to mention. None of these are without toxicity. None of these are side effect free. So these certainly all have their role, and it's really important to talk to your oncologist about what those are, what those might be. And I can touch on those, but then we'll never get through everything. But this is a very, very exciting concept, this use of immunotherapy. And then this is a schematic. This is where it goes into like the double negative. So I'm not going to get too into that. And this is just one of these immunotherapies that used also a metastatic melanoma. I do like to give a little anecdote at this point about metastatic melanoma and these drugs, just because this just shows how much things are changing. I have been on faculty here at UNM for now going on 11 years. So I'm not the most new, brand new, shining new doctor, but it hasn't been insanely long. I graduated from medical school in 2006. And I remember doing a rotation with our radiation oncologist here at UNM in, I think, 2005. I guess that's a long time ago. I'm maybe a little bit older than I think, but it doesn't seem long ago. But at that time, I remember seeing a patient with metastatic melanoma in clinic with this doctor. And he said, once these cancers cannot be taken off surgically, there's not a whole lot that we can do. We can try a few things, but chemotherapy doesn't work and radiation is not great for these. And so, he really painted this very, very, very bleak picture to me about metastatic melanoma. And, here we are, less than 10 years later from that, if that was 2005. In 2014, we started using these drugs. And now it's not at all unusual to see a metastatic melanoma patient surviving for 5+ years, since these drugs were introduced. It's not, I've seen patients that got these drugs back in 2014 and are doing just fine now. They've taken what that oncologist told me way back then and turned it on its head. Yes, they're not a cure, but they can prolong life substantially with sometimes wonderful quality. So, that's the kind of development that's happened even in the last, 8 years, 10 years, 15, 16 years, since that's what I was told in my medical school teaching. Really incredible. I'm going to skip this because that's just more schematic of that drug. I want to move on to kind of, again, these are kind of umbrella terms that I'm using to describe some new therapies. Targeted therapy. And, in ways, many of those immune therapies are also targeted. They're looking for something specific about a cell. But I kind of use the word targeted therapy when it's something looking for something specific about a cancer cell that's not using the immune system. So one idea that's also a relatively new concept that's really cool is something called antibody drug conjugates. And in this situation, this has the word antibody in it, but it's not really immune therapy, because what this is it's an antibody, a monoclonal antibody, meaning an antibody that's been made, copies of it have been made in a lab. And that antibody recognizes something specific to a cancer cell, something there that sets that cell apart from your other healthy cells. But rather than, in this case, rather than taking that antibody and using the immune system to kill that cell, antibody drug conjugates take that antibody and link it to a chemotherapy or some kind of anti-cancer drug. So in the cartoon here, you have this, I like this verbiage that we use. They call this, here's the antibody that's going to recognize the cancer right here. In this schematic, it's this blue kind of boomerang looking thing. And then it's linked to a warhead, is what they call it. That warhead is some kind of anti-cancer therapy. So that warhead may be a traditional old nasty chemotherapy, but rather than being given through an IV so it goes to every cell in your body, it's got this delivery mechanism, this antibody that's going to go only to cancer cells. And then that antibody is going to deliver its payload, that warhead, only to the cancer cells to kind of minimize toxicity and make it much more elegant, much more specific to a cancer cell. Very, very cool technology. And so some examples for that, probably the oldest one that I know off the top of my head is Kadcyla. that's given in breast cancer. That's not a brand new therapy at all. It's been around for several years now. But this concept is being developed in more and more and more cancers. Another couple of newer drugs, there's this drug belantamab mafodotin, or Blenrep, that's just brandly new, FDA approved for multiple myeloma, approved certainly within the last 6 months, I believe. There's this drug inotuzumab azogomycin. That one has been approved for a few years, maybe 3-4 years, give or take. And that one's used in acute lymphoblastic leukemia. But there's others in development and being kind of in the process of approval. So a very cool technology there. Other types of targeted therapies. So again, this is I'm going to use an example of an old drug to kind of just introduce a concept. So there's a drug called Imatinib. This is actually kind of quite old by new drug standards now. It was FDA approved in 2001, I believe. But this is used to treat a cancer and leukemia called CML. And CML is a cancer that historically, it's a slow kind of moving cancer. A lot of people don't know they have it for a long time. But once it's discovered, it has but one pathway if it's left untreated. And that is it marches and marches and marches. And eventually it becomes a very horrible acute leukemia that will eventually cause death. So the natural history of CML is to become AML, which is a more aggressive leukemia, and then it's very difficult to treat. And it's driven by a specific exchange of genetic material that causes this cancer. Imatinib, as I say, was introduced in 2001. Imatinib recognizes that protein that's made by this exchange of genetic material within the cancer cells. I'm sorry for all the kind of medical jargon for anyone who's not at all medical, but basically there's a genetic change in the cancer cell that makes a protein, and Imatinib targets that protein very, very specifically. And what I want to show you here is this is a survival curve. This right here on the y-axis is percentages of people. And as these curves go down, those are people dying. And on the x-axis, that's the number of years. And the different shades of lines here signify years. So this dotted line here is prior to 1975. And this is between 82 into the 90s and 2000s. But this line right here is after the advent of Imatinib. And so you see back in the day, we didn't have great therapies. So people would live for a few years and eventually everyone would die from their CML. But once this drug got approved, and again, now you know how to test for that specific exchange of genetic material. So again, that concept that in the lab, we know who will benefit from this drug at the time of diagnosis. Now, this curve starts to flatten. And this is probably a relatively older graph. You know, I would say this graph probably flattens and goes straight across here between 80 and 90%. Alive at 12 years plus, and many to I'd say most of these people now die of unrelated causes. This kind of cancer has just become one of their chronic medical conditions. They take a pill once a day. So an amazing breakthrough. And that concept, although this isn't a new drug, is used more and more in other cancer types as well. So one example that I always give is in lung cancer. And in lung cancer, particularly adenocarcinoma of the lung, about 10% of patients will have a mutation in something called an EGFR protein. Another 5% of patients will have a mutation in something called the ALK pathway. So again, that concept of who will benefit from a drug, because now we have many drugs that target changes in the EGFR protein. And we have a few drugs, more than one, that target changes in the ALK pathway. So if you know, this is a small percentage of patients with lung cancer, only 15% combined will have one change or the other. But if they do, you can treat them with these inhibitors. And so this is an example of someone with an ALK mutation. And on the left-hand side of the screen here, these kind of gray fingerlings are growing into this lung. The lung is supposed to be black like that. That's air. And this gray badness is cancer that's, too extensive to cut out. And we know at the time of diagnosis, because of the work that our pathologists do in the lab, we know that this patient had an ALK mutation. So we give a drug that's designed to target that mutation. And the response for this patient is absolutely gorgeous. So that's an example of a targeted therapy, looks for a specific mutation specific to that patient's cancer. And we know that that mutation exists because we look for it. So if you give this drug to everybody with lung cancer, it's going to work in only 5% of patients. But if you don't waste everybody else's time and you only give it to that 5%, you get a much nicer response. Another example of a targeted therapy, this is another melanoma example. We know that many patients with melanoma will have a mutation in a protein called BRAF. That's just one, if you think back to that picture of the cell and all the different signaling pathways inside, one of those pathways has a protein called BRAF. And in some melanomas, not all, and we look for this in every patient, there's a mutation in that BRAF pathway. And if there is a mutation, there's a drug that targets that mutation. So you can't use this drug in everybody that has melanoma, but you can use it in people who have this BRAF mutation. And now there's even newer drugs than this that target those mutations. But it interrupts that pathway and is very, very, very helpful in treating metastatic melanoma. A drug that, if you remember, I said, I was told years ago there were no options for. And this is a schematic. Again, this is a cell. Here's the surface. BRAF is one of these signaling pathways that in some melanomas is just broken. It's constantly signaling, saying, make more of the cell, make more, make more, make more. Vrafenib and its newer kind of cousin drugs go in and stop that feeding mechanism and stop the growth of that clone of cancer cells. Another kind of idea and newer developments in cancer treatment is the idea of personalized medicine. And, a reason that I really, really focus or repeat throughout this talk to your oncologist to make sure you keep channels of communication open. It hardly does any good anymore to say someone has cancer. That's a huge term. There are so many kinds of cancer. And even to say someone has, lung cancer, someone has bone cancer, someone has brain cancer. Under each kind of cancer, there are so many different kinds. And when it comes right down to it, every single person's cancer is a little bit different, driven by the changes in the cellular machinery that made that cancer. And so this is also kind of a cutting edge type of medicine that we can, now have the ability to sequence the genome of a cancer. If we in general can sequence the genome of a person, we can get a cancer cell and sequence the DNA within that cancer and look for mutations. And once we know the genetic code of a cancer cell, we can say, this cancer cell has X, Y, and Z mutations. Do we have a drug that targets those mutations? And so there are different tests that can be done. I put Foundation One is one commercially available test that we use in clinic. Generally, we use this when other therapies are not going well or have failed us or have kind of made the progress that they're going to make. What we sometimes do is do Foundation One testing or some other kind of genetic testing of the cancer cell to look for what we call targetable mutations, is what you'll hear us say. That means that there exists a drug that works in that mutation. And so that is something that your oncologist may talk to you about at some point in time. Now, oftentimes we find laundry lists of mutations, but none of them have a drug for them. Other times, we find a mutation that has a drug, but it turns out that that mutation maybe isn't the one that's what we call driving the cancer. So this sounds very exciting, and it is. It's very exciting, very cool, but it's also not, none of these things are 100% slam dunks. These are all areas of tremendous progress. There's incredible progress still coming. But again, it really requires that back and forth with your individual oncologist. So I kind of want to start to close out this talk with 3 takeaway points. Advances are coming hard and fast. You know, this oncology is a booming industry. And so, you know, keep hope alive. Changes are coming. We're learning things every day. Another just a personal example that I give, I treat personally, just in my clinic, I treat a lot of multiple myeloma. I have a 6-year-old son. So I was out on maternity leave 6 years ago. I took, give her about 12 weeks off from his birth in September until just after the winter holidays. In that period of time, when I came back to work, 4 new drugs had been approved by the FDA just for that one cancer, for multiple myeloma. Just insane boom. I was like, I had patients that I've been kind of, gosh, we're at the end. What else can we do? What else can we do? Now, all of a sudden, I've got 4 new possibilities sitting in my lap. There's actually been another boom here within the last six months or so for multiple myeloma, where I'd say at least another 3 to 4 drugs have been approved just in that one cancer. And this is happening in cancers across the board. So, definitely your conversation with your oncologist may change from one visit to the next, just depending on drug development. So, again, keep those communication channels open. Another important point, though, is that none of this is magic. None of this is one thing that's going to fix everything and that's going to work for everyone. These are just concepts. Some of them may be curative. Some of them may work for others forever. Many others may not. Many of these are still designed to help with symptoms or to buy time. These are not a promise of immortality. So it's really important to maintain that good relationship with your oncologist. Also, kind of within this idea that none of these is magic, I think I paint a very hopeful and excited portrait in this talk, because it is a very exciting and hopeful time in oncology with many advances. But I made this point once, none of these are without their side effects. None of these are toxicity free by any stretch of the imagination. Some have minor toxicities, most have major toxicities, and definitely things that you need to be aware of. So again, that relationship with your oncologist is key. How to recognize those, when it's worth taking the risk of a certain side effect, and how to manage those side effects if they should happen. And again, I can't emphasize this enough. Every cancer is different. Every patient is different. Every patient's cancer is different. Every patient's values is different. Every patient's tolerance is different. Every patient's life is different. But they can and can't do, will or won't do, want to or don't want to do. And so, again, that kind of goes back again to make sure that you're comfortable talking with your oncologist. So care really has to be individual. And I just, oncology is a hopeful area, and it is changing every day. I think I see something. Sorry, I didn't see this. Maybe it was just a question that just came in. I'll just start reading some questions. I don't know if you guys can see this, so I'm just reading it. This question says, I am in Aurora, Colorado, and being seen at the University of Colorado Anschutz. ADT failed for metastatic prostate cancer this summer after 2 years, did foundation tests, and am now on targeted gene therapy, olaparib, a PARP inhibitor for CDK genes, for 1 month, hoping for the best. Wonderful. I hope the best for you too. Yes, that is a very that's been a very interesting and important development in prostate cancer, and I wish you all the best. I hope it works. Another question, once treatment has led to a CR in multiple myeloma, do you recommend that patients stop all treatment? Oh, that's a tricky question and a really good one. I think that is very patient specific. Myeloma, as I mentioned, that's kind of one of my areas. Myeloma is a rapidly changing area. Historically, when I was taught our thinking in myeloma is that with the new therapies, which have been revolutionized since about the mid to late 90s, when we stopped using so much traditional chemotherapy and started using the immunomodulators, the proteasome inhibitors, the monoclonal antibodies, the newer therapies that we have. Survival went from being across the board less than 5 years to now I think of it as more of a chronic disease. But the paradigm has always been that we don't think of it yet as a curable disease. And that may or may not be changing. It's certainly evolving. But for the moment, I tend to guardedly, I just keep my guard up with multiple myeloma, still hesitate to say it's curable. It'll go away forever and someone with myeloma will live a long life and die of something else. Now that may or may not happen because it is becoming such a chronic disease. And I have patients that have been on and off therapies for approaching 20 years with, in some situations. And it's very individual a lot of times what we'll do is treat into remission and then do some sort of maintenance, something that can fit into life a little bit easier, a little bit better, something oral, something less frequent. I do have patients on occasion where we've stopped therapy for various reasons. And I have patients where that seems to be going just fine, where, I see them every few months and it's like, nope, still not there. I have some patients that have gone on for years like that. So it kind of requires a lot of individual judgment. I tend to think that's the exception rather than the rule, but it's not an unheard of or infrequent exception. So that's one where there's a lot of back and forth and kind of risk benefit discussion to be had. I think it's possible to stop all treatment, but there's a lot of specifics about a person's multiple myeloma, what kind of, there's some risk stratification that we do up front that I think should definitely be a conversation about whether it's a good idea to stop myeloma therapy or not. There's another question in gynecologic cancers. Typically, when is immunotherapy a good option? If I am going to have to, I am so sorry, I'm going to have to defer that question. We tend to get more and more subspecialized in our practice. And I do, to an extent, practice some general oncology because I teach our fellows and I see all comers in general. We're very fortunate and spoiled at UNM to have completely separate, completely brilliant gynecologic oncologists or oncology colleagues who take care of gynecologic cancers. And I would imagine that immunotherapy is kind of working its way into their world, but I am less familiar with exactly when and where. So I would encourage you to attend their Ask the Oncologist panel and ask one of them. I don't want to give you misinformation.
Okay. Any more questions? Oh, there's one.
Oh, is hemophilia cancer? No, hemophilia is definitely not cancer. It's in my bio just because it is part of what I do as a hematologist at UNM, but no, hemophilia is sometimes genetic, sometimes autoimmune bleeding disorder, but definitely not a cancer. Will thyroid cancer respond to immunotherapy? Another good question, and another one where thyroid cancer is a particularly tricky one. I believe there is some role, but that's another one where that is another very, very subspecialized kind of cancer that sometimes we see as medical oncologists. Our typical Usually a thyroid cancer, when it's not just a surgical problem, when it can't just be cut out, generally the treatment is, depending on the type of thyroid cancer, again, some of those examples where it's not just one cancer, there's different subtypes, but generally speaking, it starts with treatment through an endocrinologist with iodine treatment, with radioactive iodine, and that can be given and repeated, and that's usually the first many lines of therapy if something other than surgery is needed. Beyond that, for many thyroid cancers, if it's something that needs systemic therapy or medical therapy, we use more kind of, I'll say, biologic therapy or tyrosine kinase inhibitors. And so immunotherapy is not usually the upfront therapy that I know of. I would definitely ask that question in the head and neck panel, because my personal, my personal experience with immunotherapy and thyroid cancer is not there. So I would definitely ask at the head and neck panel. I know that that's kind of the general approach for upfront and for the first lines of systemic therapy. And there's another question, what type of cancers cause tumors all over the body when not treated? Actually, a lot of cancers will cause tumors to come up all over the body. Almost any cancer can do that if they're not treated. Any cancer that has what we call metastatic potential, or the potential to spread, which can be anything from lung cancer, breast cancer, sarcomas, colon cancer, prostate cancer, ovarian cancer. Almost any cancer can go anywhere and everywhere when not treated. Okay, papillary thyroid cancer. I would definitely defer to my head and neck colleagues, because that's kind of another one that's kind of newer and upfront, or newer and cutting edge in its use.
I think we're out of time. Darn, we could listen to you talk all day, Dr. Quintana.
Thanks so much.
Wonderful.
Thanks so much for having me, and thank you all for coming. I hope you have a wonderful weekend.
Well, thank you for sharing your time with us on such a busy day, and wish you the best. Enjoy the holidays, and thank you so much again.
Much. Same to you. Bye-bye, everyone. Have a wonderful weekend.